to present her talk on minimum documentation for standardization. Dr. Samina is the Chief Medical Director of Zamindar Microsurgical Eye Care Center, Bangalore, was awarded as Young Quality Achiever and also a NABH assessor.
Excellent. So at the outset, I would like to thank CAHO, AIOS, and of course, Dr. Nirmal Frederick for being the champion for this cause. We need to understand that quality is not the prerogative of big corporate eye hospitals. The smallest of small eye care practice in India can start their quality journey, and this webinar is all about that. It is very simple, and whether or not you're looking at accreditation, starting your journey straight away, just by following some of the things which were mentioned in this webinar, you can structure your practice. Nobody wants chaos, right? And any structure can sustain only if it becomes a culture, right? It can sustain only if there is a cultural change. So what needs to be done for a cultural change? For a cultural change, everybody, each and every person in the team, from the doorman to the chairman, has to be on board. They should believe, and there's something known as organizational citizenship. The loyalty for your own organization should be fierce, not just with the owner of the organization or the doctor leading the practice, but each and every member of the team. And for that, the credit of the outcome should be given to each and every member of the team. That's very, very important. So let's begin with the most basic structure of any structured organism. Say, let's for a minute forget that we are having an NABH discussion. Let's see that let's have a 6S lean workplace, right? Any eye hospital, let's say that tomorrow onwards, I want to look at this new model where I sort out, keeping only what is necessary and throwing out what is unnecessary. So many times we see in operation theaters that they are act as storage rooms. Anything unnecessary is stored in the OT, right? So think right now when I'm talking to you, just maybe for a second think, is there something in your hospital which should be just thrown away? Yes, there must be something. Set in order, orderliness, arranging and labeling only necessary items for use and return by anyone, right? That is very, very, very important. Shine, it should be so clean. Every area should be clean and standardized. That's my topic for today, the documentation for standardization. It's actually the minimum documentation for having a standardized practice. Sustain, sustain, and sustain. How do you sustain, right? By monitoring, by having systems in place to monitor what's happening in your organization, and safety, accident prevention. And I think a colleague of mine has already spoken about an incident reporting culture, right? Japanese believe that an incident is a treasure, an adverse event is a treasure. You learn from it. So instead of penalizing the staff for bringing out an adverse incident, you're going to actually award them that they had the guts to bring it up, because from that mistake, if you learn and set in a preventive action, then many other patients will be saved. So let's talk about the levels of documentation which are required. This triangle shows very clearly that the bottom of the triangle are the external documents, the statutory and regulatory requirements for NABH. Then comes the records, formats, registers, and forms. Then the work instructions and the SOPs, the standard operating procedures, right? And then we have documented policies and procedures according to the NABH standards. So for example, you say an organization should have this. You say that we, say for in my case, Zamindar's Eye Hospital has this. That's how you make a statement of your policy. And the manuals, there are some very mandatory manuals in your organization, and at the apex of all this thing is your apex manual. That's the Bible of your organization. That's the most important manual of your organization, which talks everything about your organization. So these are the levels of documentation, and let's in the beginning itself eat the frog. That means let's understand what is documentation is mandatory. Many times we hear our colleagues talking about, oh, NABH is all about documentation. That's not true. It's not that each and every standard which is written in the NABH standards book needs to be documented. There are some standards which say, for example, I've taken the example of COP8, Care of Patient Chapter, standard number 8, that says there are documented policy and procedures to ensure care of patients undergoing surgery. So wherever you see that there are documented policy and procedure, That's the standard where you need documented a policy and a procedure. You need a standard operating procedure. That means these are the critical areas of your work where you need to work with an SOP. And these are the pillars of quality. Let's not even like what I said before, even if you're not talking about NABH, don't you think that if you're operating, that's the most critical area of your work, and you need an SOP for that? Who is going to do what is happening and how it is happening? Then you have records and registers to show that the work is done, right? And who has done the work, accountability. And then you have checklist so that you do not rely on memory. These are the pillars of quality in terms of documentation, and these are mandatory whether or not you are looking at accreditation. So now let's come down to the SOP, the standard operating procedures. Say we talk about an HIC manual, right? And there in any SOP, when you release any SOP, for the smallest of the small things, you should have an author, somebody who has written the SOP. That should be preferably written by the person who's doing the job. I had met a doctor some time back and he said, oh, I'm booking at NABH, but for the last 1 year, I'm writing SOPs. I said, you're writing SOPs for who all? He said, for everybody. No, you're not supposed to do that. You are not a front office staff. You are not a nurse. You are not a manager. You need to write SOP for your work, what you're doing. And everybody should be allowed to write their own SOP in whatever language, whatever grammar. Then somebody, a senior person in that department, or you in a small organization, can review that. And if you can, and somebody higher up can approve. If not, you can approve it, right? This is the way you write an SOP, and it should be published and released in a big hospital by the quality department. Then there should be recall meetings and yearly maintenance of the SOP, right? That if there is SOP needs to be updated, especially the HIC manual, the hospital infection control manual needs to be updated once in a year. So you have an author, a reviewer, or approver of an SOP. And that's beautifully how you write an SOP. Nobody expects from you that you have a very crisp SOP the very first time your organization is assessed. So don't get carried away with the loads of very crisp SOP which somebody might supply to you. A consultant might give you and say, just upload these. Kindly do not upload those, because when the NABH assessor sees that you are the first time applying for this and you have such crisp SOP, it's almost impossible to do that. A beautifully written, a simple SOP will win the heart of your assessor, because that's the true SOP which your person, your staff has written, right? And that's the grassroots of any quality change. Looking at exactly what you're doing. When you start that process of writing SOPs, you will be surprised that, oh, but ये तो हमने ऐसा नहीं किए था. अरे ये तो बदल के ऐसा हो गया है अभी. So that discussion itself is the grassroots level quality improvement. And please do that. Have a SOP meeting with your staff and find out what each and everybody is doing and how they're doing it. Let them write it down. The minimum documentation is obviously the first thing is the essential SOP. Like in the standard, these standards, there is an asterisk and it is written that documented policies and procedure or training is required. So you need training notes for that. So that is the essential SOP required. That's the minimum documentation. HIC manual, it's a minimum documentation, right? Which is required in an organization. You need to have, like what I said, at the APEX manual. I will talk about the APEX manual in my next slide. You need to have a safety manual. If you have a pharmacy, you need a pharmacy manual. And obviously, like we discussed about the HR department, you need to have personal files for every staff who works with you. And if there are committee meetings, you should have meeting notes in a very structured manner, right? That what was decided and who was the person, and if there was some action to be taken, who is the person responsible for that action and what is the deadline for that action. And in the next committee meeting, the first thing what you do is discuss the minutes of the meeting of the last committee meeting, so that what was discussed earlier is not forgotten. Then obviously you need training records. We heard a wonderful session about, talk about training. So every training, including this one, should have a training record. Who all participated in the training? What was discussed in the training? Who were the absentees? And there should be a training of the absentees. So training records also become a part of the minimum documentation required, right? You might say, I have done so many trainings, but you need to have a proof that the trainings were done. And then forms. Forms can be OT related. We looked at all the forms in this session already. Incident reporting form is something very important which should be available in the organization. And everybody in the staff should be empowered to fill up an incident reporting form. A code blue form, I'm just giving you some very important examples, right? We might say that, oh, there was no death in our organization for so many years and God bless, it should not happen. But if it does happen, then you should have a code blue form suggesting that when there was a arrest, you did call for a code blue, and there was a systematic minutes of the meeting were recorded and the procedure was done. This might save you in a court. Apex manual, like what I said, I'm going to talk about the Apex manual. Why is it at the Apex? Why is it the most important manual of your organization? Because it tells what you stand for, who is the owner, what was the history, what is the mission, vision, quality values, what are your scope of services. Remember, everything in NABH revolves around the scope of services. Yeah, everything, what you need, what you should have is what you write in your scope of services. So do not write anything extra. Write things what you really, for which you have the infrastructure and the resources, the statistics, the organogram with the committee and the statutory licenses, details of staff and employees, all policy from all chapters, the quality initiatives, what you're doing is your Apex manual. Patient safety goals. We've already heard about everything about it. I'm not going to go into detail, but in the safety manual, this is what is going to be there. What are the risk factors in your organization? Who can tell that the best? Not me, it's you, right? And you should write down all these things and find out what are the risk reduction methods you can do for the possible risk in your organization. And after that, write down that in case after the risk reduction measures, if there is a risk, then you should be doing risk management strategies. For that, you should have your rapid response teams for all the codes, the code blue, the code pink, the code red. And that's all about the safety manual. Along with that, it includes the facility safety rounds monthly basis. It includes everything which makes your organization safe. Surgical safety checklist. Yes, there was a question about the surgical safety checklist. And yes, this gentleman, Atul Gawande, who's in Boston right now, introduced a surgical safety checklist, and we should be using it. And it's not a piece of document. In fact, what WHO says that it's not even bothered whether it is signed or not, because it should be actually played out in the operation theater, a sign in, a timeout, and a sign out. With every single case, this has to be a mandatory part, obviously, of your OT documents, but not that it requires a signature. It has to be played out like a role playing in the OT with every single patient. Registers to be maintained in the OPD, accident register or the MLC register, the medical emergency register, a transfer register, a verbal order register. If any particular medicine has been given over phone, then the doctor who has given that medicine should be able to sign in that verbal order register the next day within 24 hours. An adverse incidents register in the OT and the OPD. Registers in the OT, I think we have already discussed, but just to complete the list, I would like to share this also, that there should be registers for every single thing in the OT. An OT list becomes a very valuable piece of document. It should be released 24 hours before the surgery. And all relevant details, I think Dr. Sean already showed his OT list, which was a wonderful piece of document. We have to take the OT list seriously, and every possible detail of the surgery should be there. It's training, and some more training. So we already said that, training is done, and training record should be maintained, right? Training can be done by the staff themselves about the equipment, what they're using. A training can be done by themselves, how to use the equipment. And what is the routine maintenance for that equipment can be a part of the training. What I forgot to tell you in the safety manual is that equipment safety becomes a very important part of your safety manual, and training for that has to be given. So yeah, just some pictures from our organization. The document control is very important. Whenever you make a register, you see that you have a control over that particular document or that particular form. Everything has a document control. What is the name of the register? What is the number? Which is the place it should be there? What was the date when it was made? What is the retention period? Who is the person responsible to maintain the register? And the quality manager's signature. So document control becomes a very, very important. Just having a register is not enough. You need to have a document control for each and every register in your organization. All medical records should be legible, complete, accurate, and chronological. Legibility to be ensured in all entries made in the patient file. All medical records need to be complete, accurate, and chronological. Sign, name, and date and time below each entry in the medical records is a must. This is very, 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 very important. You don't know, if you do not want to have a complete signature in every place, the abbreviation of the signatures of the authorized people should be available in the organization so that you can, you have your short sign in the medical records. So I think I quickly finished this talk in interest of time. Thank you very much. I bring a lot of greetings from my entire team from Bangalore. I'm very proud to say that we are a small little organization, but this year we were the recipients of the Patient Friendly Award from AHPI. Thank you so much once again to Kaho and Dr. Nirmal for letting me be a part of this wonderful, wonderful webinar. Thank you.